Ryan Stanton here with ACEP Frontline, joined today by Dr. Kevin Biese, who's a wizard and specialist at the art of geriatric emergency medicine, actually a consultant and specialist with West Health, who's working on this particular area of medicine, this incredible area of medicine, because it's something over the next number of years, we're already into the blue-haired or silver wave, whichever way you want to call it. As the baby boomer generation ages, we're going to have significant impact on emergency medicine with geriatrics. And just as we have had focus on the past on pediatric emergency medicine, we now also are realizing the special needs and consideration for our geriatric populations as well, who are increased risk of illness and trauma, but also at potential challenges within the emergency department and healthcare system as well. So Dr. Biese is going to talk with us about that, to give us a little bit of background on yourself, and then we'll roll right into this.
Yeah, thanks, Ryan. Yeah, I'm an emergency medicine doc who spent a lot of years trying to improve care for older adults in the emergency department and work with a lot of great colleagues around the country. I'm based at the University of North Carolina at Chapel Hill, and also do work with an organization you mentioned, West Health, that's a philanthropic group trying to make emergency care and other types of care better for older adults across the country.
Fantastic. And let's talk about, I mentioned it already, a little bit of the growth of the population, but give us the reasons, some of the reasons why this is such a hot topic right now.
Yeah, I think the reasons are apparent to all of us, really. So at a clinical level, we've done extensive studies, and it turns out that older people get sick and come to the hospital, and often via the emergency department. Like, time after time, data shows that old people get sick, and so to us they come. And and we're great at treating them. I mean, in many ways, emergency medicine does a great job. We certainly are great at thinking of life-threatening diagnoses and making sure we exclude a lot of bad stuff. But in many ways, the system is stacked against us for really meeting their needs. So at a clinical level, the reason this is so important is because we haven't really been given access to, on a large scale, to pharmacy resources that could help us make sure we can manage their medications right, or case managers that could help us get us resources in the community. I mean, we all know sometimes people come in because they have heart attacks. Sometimes they come in because their daughter left town, and you've got to figure out how to help take care of this older adult. And we haven't done enough education along the lines of how physical disease manifests differently in an 85-year-old than in a 40-year-old. So at a clinical level, there's some work to be done in education so that we can be more discriminatory about how we treat older adults. And even more importantly, some work to be done about bringing in interdisciplinary resources into the emergency department, either on site or in smaller hospitals via telemedicine resources, to help manage complex medical and social patients in the best way possible. So that's the clinical. Go to the ER, who do you see? A lot of older people. I mean, we went there, I say I went into this specialty for chest tubes, helicopters, and machines that go ping. But now, I go to work and it's like, what am I going to do with Miss Smith, who's 87 and moderately demented and doesn't have a place to live? That's a lot of, what we're addressing every day. At a national healthcare level, so that's clinical. As far as ACEP and emergency medicine leading the way forward in healthcare, we spend 18% of our GDP on healthcare. Holy smokes. I know we all know that number, but that's almost $1 in every $5. Holy smokes. And a lot of that money goes towards care at the end of life. A lot of that money probably goes towards care that is inconsistent with the patient's wishes. And a lot of those decisions about where people get care happen in the emergency department. Over 60% of admissions to the hospital of patients over age of 65 come through the emergency department. We're the ones that have to make those decisions, and we make the best decisions we can. We try and do what's right and safe for the patient. But if we're going to have a sustainable healthcare system, and if emergency medicine is going to lead this transition towards some sort of value-based care system, there's lots of models, and we're sort of drunkenly stumbling towards value-based care, but towards some sort of value-based care, then we need to do it in a way that better identifies the care wishes of older adults and meets those, and when possible, meets them with community resources as opposed to in the hospital. So we can lead the healthcare system in value-based care transformation, and frankly, we need to, whether this is what we signed up for or not. It's the role we're in. And we need to do it to be more clinically empowered to meet the needs of our patients on a day-to-day basis.
Geriatric medicine, interestingly, most things we see a lot of times in emergency medicine, especially with young, it's a one problem issue. Geriatric emergency medicine definitely has often will have some sort of complicator, whether it's the fall on an anticoagulant or whether it's somebody with sepsis but also has a history of kidney disease and heart failure. There's always a lot of complicators in there as well, but also our environment itself can pose some challenges to the geriatric population. What are some of the things that current, or at least in the past, state of emergency medicine can be challenging for the geriatric population?
That's a great question. The first thing I'd respond to there is to Google geriatric ED guidelines. They came out in 2014. It's not that long of a document. There are a lot of bullet points in there, and it specifically addresses a lot of things. So if you forget what I'm saying or I forget to say it, there it is. A lot of it is sort of no-duh type stuff. I wouldn't want my mother in the hallway of a busy trauma center emergency department for 7 hours. Mm-hmm. None of us would. And none of us would want each other's mothers there. But walk into a busy trauma center in the United States right now, and who are you going to see lined up in the hallway more often than not? And why? Well, so many things happen. One, it's deliriogenic, so they get more confused. Two, they're separated from their family sometimes because it's hard for their family to be with them when they're sitting in the hallway, and that causes problems. Three, it's harder to get them food, get them beverages, help them use the restroom, right? So then sometimes, this is less after the CAUTI rules, but sometimes, they end up with Foley's, and then they end up with, urinary tract infections. And none of this is happening. So the physical environment makes it really challenging. The time constraints make it, let's be honest, we have got to move people through because we got a bunch of people in the waiting room. And we've got to do that. So the time constraints make it tough. The physical constraints make it tough. The fact that sometimes the hospital doesn't really know whether we're inpatient or outpatient and give us all the resources we need all the way down to dining to help patients out. All of these things make it really challenging to do a good job taking care of older adults. And so some of it is structural and some of it is process, but we can hurt older adults by the way we currently deliver care.
Absolutely, and just even considering the fact that our beds in the emergency department are not good for an elderly, especially a thin elderly patient to be on for an extended amount of time. Increased risks of pressure, sores, discomfort, back pain. Our beds are made for quick cleaning and sterility and the idea of quick transition. And, so even the beds are a challenge. The risk of falls. There's a lot of wires and cables sitting around that can tangle up granny, slick floors. There's a lot of different things that can be challenging, and in fact, there's a ton of stuff in there. There's a lot of reasons people can decrease their accessibility. Many of our rooms aren't accessible for walkers or wheelchairs, and so, a lot of things about emergency departments kind of work against our elderly patient clientele. And you guys have worked on making steps to certify geriatric and emergency departments, just like we certify pediatric emergency departments. Looking at that specialization, not even completely separate or specialization, but at least having the supplies, attention, consideration for our geriatric population. Talk to me about some of the thoughts and ideas behind the GEDA program.
Mm-hmm. Yeah, so what is a geriatric emergency department? Just to back up just a second. I think a geriatric emergency department has 4 parts to it. It has the structure, which we just talked about, right? You don't want to be on a cot in the corner of the hallway for 12 hours. No one does, and the vulnerable patients amongst us will suffer the worst. And there's all kinds of things you can do to make the structure better that are not super expensive and don't require like $1 million grant. It has the community connections. You want to have the ability to get people community resources, Meals on Wheels, Area Agency on Aging, a primary care visit the next day. Holy smokes, blow your mind. Remember, these people do have Medicare, most of them, so sometimes they have an easier time getting a PCP than other folks. The third thing it has is education, some level of nursing and physician education about the specific needs of older adults. And the fourth thing it has is processes. triage things. So you kind of do some triaging at the front door, like the identification of seniors at risk, or the get up and go, or the BCAM to identify delirium. These are all less than 2-minute triage things. It's super quick. You don't have to do them all the time. You got to figure out how it works into your workflow. But then for these high-risk patients, you've got some way of having someone talk to them at greater length. So all of these things, processes, community connections, education, and structure are sort of the 4 pillars of a geriatric emergency department. Right now in this country, there are over 129 self-identified geriatric emergency departments. But the quality of the care that's delivered there varies tremendously. Literally, from one place we went to we said, hey, you said you've got a geriatric ED, what is it? They took us to a box of unopened hearing aids. I kid you not. They're like, here it is. And we're like, no. And then to other places like University of California, San Diego, or Mount Sinai, or St. Joseph's, the first 3 level 1 accredited geriatric emergency departments in the country, where you'd walk in there and they have all 4 things I just said as far as the 4 pillars, and you'd be like, I would be like, this is a place I want to take my mom. They don't have everything perfect, but they got it right. ACEP created the accreditation, Geriatric Emergency Department Accreditation, GEDA, to recognize those emergency departments that were striving and accomplishing doing a good job for older adults in their emergency departments, and sometimes even a great job. 3 levels. Level 3 is the easiest to obtain, and the key there is creating a team that's improving processes and some elements of care for older adults, up to level 2 and level 1. And essentially, there are 27 best practices in the geriatric ED guidelines I mentioned earlier, and a level 2 has to do 10 of those, and a level 1 has to do 20 of those. UCSD doesn't do the exact same 20 of those as Mount Sinai because they have different resources. But they say, this is best practices, we're going to strive towards this. And what's exciting is once you start to bring an interdisciplinary team around trying to make care better for older adults, everybody gets it. This is not rocket science. That's why I do this. I didn't have to be a genius to figure out that we should do this better. Everybody gets it, and they get empowered, and they're like, oh, we can make things better. Oh, holy smokes, PT can come to the ED and get reimbursed for it. You know what? We can get a decent meal. It doesn't have to be a frozen meal. Some of this stuff can actually happen. They can open the closet with the walkers past 5 p.m. Whoa, blow your mind. Once you start to have success stories, they pile on top of each other, and you watch care transformation happen. ACEP recognizes those institutions, gets information out to the CEOs celebrating those institutions, and actually gives marketing materials to those places to let their community know that they're great at taking care of older adults.
So how is it that folks get engaged and involved with this certification? It sounds like you've got, or the accreditation, it sounds like you've got, a number out there self-proclaimed. Sounds like you have a few that are kind of top tier level 1. How do folks really kind of get the ball rolling with their department? Google
ACEP GEDA, GEDA, or Geriatric ED Accreditation. There's an online application form. We haven't even started marketing. I guess this is sort of a version of that, an accident or not. We just did our pilot round. So we certified 8 programs, 3 level 1s, like I just mentioned, and 5 level 3s in Aurora Healthcare System in Wisconsin. We have 27 other places that have done their applications and over 70 lined up that have already reached out to us. And we're gearing up our ability to deliver and do site visits when necessary and get folks signed up. But if you Google Geriatric ED Accreditation, you'll find the application. It's not meant to be overly onerous. You'll find people you can call and email to help guide you through it. Our goal is to help hospitals and emergency departments do this. There's not meant to be excessive barriers to making it happen. I'm firmly convinced that all 4,500 EDs in the country can together take steps forward to making care a little bit better for their older adults.
What are some of the, it seems, it is obvious that it would benefit our patients, benefit our geriatric patients. What are some of the, just to say, well, we'll make it easier, we're going to handicapped accessible bathroom, we'll do this, we'll do that. Really, what are the outcome differences that we can expect by actually dedicating resources and an emergency department to geriatrics?
Perfect. So let's think about it from 3 perspectives: patient, payer, provider. Patients, yeah, I think we get it, Payer. So there's data, it was in Journal of American Geriatric Society, I think in March of this year, from GEDA-wise, showing that with key personnel in the ED, like social workers and geriatric trained nurses, you were able to decrease 30-day readmissions, which just makes sense. You better discharge people and transition them back to the community. In geriatrics, we use the word transition back to the community rather than discharge, because somebody's kind of always got to own them. And there's just data that was released in an abstract that showed physical therapy, places that were able to get physical therapy in the department had decreased rates of readmission as well. So since 30-day readmission is a hot topic for CMS, we focus on it a lot as endpoints, and a lot of the interventions we recommend are beginning to have data that show that they positively impact readmission rates. So from a payer perspective, be that a Medicare Advantage program, over 30% of the older population is on MA plans now, or strictly fee-for-service CMS, there's a lot of interest there. From a provider, and by provider in this case I'll use hospital. From a hospital standpoint, it's really two benefits, and which one fits your healthcare system is a little different from system to system. One is, to be frank, market share. It's America. Hospitals thrive by being the place that the community wants to come to get care. And being a place that's recognized that you want to take great care of older adults, much in the way that pediatric emergency departments did this, doesn't just attract older adults. It attracts the community to saying, yeah, I mean, this is a place that cares about us. So many of the interventions we're recommending are so concrete, like meals and kindness, that it can't help but send that message to the rest of your family that this may be where you want to get more intensive interventions when medically indicated as well, surgeries, et cetera. Also, on the hospital side, correct allocation of bed uses is key. The DRG return on unscheduled Medicare admissions is whether you're going to make any money on it, like it's dicey. But if you want to get strategic, and certainly if you want to transition to any sort of value-based care model, what you want to do is get the right person in that bed. So if you can increase your market share and successfully send home some of the people that don't need to be admitted by getting them a doctor's appointment, having home health care, see them the next day, whatever's indicated, and then save your beds for the people that really need those interventions, that's a much more financially sustainable model.
Well, not to mention that, it's getting these patient populations into the emergency department and getting them in the hospital. I mean, a lot of it sounds like, not only the safety aspects of it, but the resource necessary, because we do admit a fair number of elderly patients or geriatric patients, not because of the level of acuity, but many times the availability of resources either at their home or at their facility. And can we avoid those? We're finding more and more often now that, when I talk about ICD-10, or we talk about all the different legislations and CMS and guidelines and metrics and things like that, there's nothing that is being placed by these organizations as an effort to reimburse us better. It's actually more ways to make it more difficult in order to cut reimbursement, to save dollars, to say it's your fault or whatever it may be. And so, the opportunity there to streamline this, and as you mentioned, absolutely, is to get the right patients in those beds and dispositioning the ones that we can disposition. You talk a little bit about that, and you mentioned a little bit at the beginning, but talk about a little bit that care, the importance of that care coordination, and that how these types of programs can help facilitate getting Granny to the right place, right disposition place.
The hospital, with all due respect, the only reason to be in a hospital is the only perfect reason is if you need a medical intervention that can only be done in the hospital that's consistent with your care wishes. Otherwise, our challenge as ER docs is to try and find the best place for you, and people would rather be at home than in the hospital when they can be. So how do we set that up on an outpatient basis? And it's just the right thing to do. It's also, ACEP has recognized it's a way for emergency medicine to help lead the necessary healthcare transformations. We're not part of the problem, but we need to be leading the solution. And I think this is really a way for us to say, yeah, we're going to be smart, we're going to do this right, and we're going to help connect. The ED is not the front door of the hospital. It should be the front porch of the hospital. You don't always have to come inside just because you came to the emergency department. And maybe you can get the social and medical resources you need to go back home.
And maybe as simple as getting some sort of assistance device, oxygen, or whatever it may be. We've had I've had patients I've had to bring in because of those resources, especially working nighttime.
Yep.
And I've had folks I've been able to send home because we were able to work it out. Just had one a few weeks ago where she was going to have to be admitted to the hospital for a pelvic fracture, because she had steps and didn't have a walker, didn't have a wheelchair. We were able to arrange the walker and the wheelchair, and then our fire department said we will be happy to meet her at her house and get her into the home so she can go home. And that she was happier, family was happier, our system saves money from that. And then they even offered to come help her out and get her to the vehicle when she had to go to her appointment the next week. And so, those are the things, so much of healthcare, and those are considerations that our reimbursements make, and with a narrow margin, can we conserve and preserve many of those resources? Our hospitals are running at higher capacity than ever. I remember when just a few years ago, when anything over 80% was thought of as a disaster type situation, but now many of us are running greater than 90% capacity most of the time, and the idea of boarding and throughput and disposition plans, it's all very important to consider, especially in this sensitive population that is going to be growing in our emergency department year after year.
And the key, absolutely. If you're like listening to this or read about it and you're like, yeah, I want to advocate for this, right? We have to keep throughput in mind. We're still the emergency department. So the key is when we set up these systems to be looking at some of these social and follow-up issues from the time the patient hits the door. They don't have to be done, it doesn't all have to be done by the physician, and it doesn't all have to be done sequentially, right? Because then you're increasing length of stay. So whatever case management resources you can tie in or nursing conversations, you kind of know within like a couple minutes whether there's a reasonable chance medically this person could go home. Start figuring that stuff out up front, because you have to address throughput as you do this. We can do this in a way that doesn't have to add on to throughput, and if you don't have them waiting for beds forever to go upstairs, you can decrease throughput. One great resource for learning more about geriatric emergency medicine and how to best treat our older adults in the ED is GEMCAST, GEMCAST podcast on iTunes. Comes out every other month or so. Very practical information done by Christina Shenvy and the people she interviews on how to take good care of older adults in your ED.
Dr. Kevin Biese talking to us today about the Geriatric Emergency Department Accreditation Program, gotten started from ACEP, addressing a very important population of our workspace and a growing population that we're going to see. How can folks get more information if they would like to contact you or have further questions?
Please don't hesitate to reach out. My email is kbiese, K-B-I-E-S-E, @med.unc.edu, or just Google ACEP Geriatric Emergency Department Accreditation. You'll get myself or Nicole Tidwell, who runs the program for ACEP, and we'll get on the phone with you or email with you and help you figure it out. It's a great way to do better by our patients and lead the healthcare system in the direction it needs to go.
It's something we all need to consider, and we need to make sure, even if you don't go for the accreditation, at least looking up the information and the facts about what you can do in your department to help make things better for our geriatric consumers and population, not only from an NER evaluation standpoint, but also disposition planning and considerations, just as we mentioned, as simple as using the restroom or our beds that we have in the ER. As for me, you can contact me at youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com. That's at everydaymed on Twitter. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.